All right, we are now at quorum. Good morning, everyone, and thank you for attending our DUR board meeting in August. As a few reminder for your meeting today, if you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. DUR board members, please preserve your question until the end of presentation or ask in the Google Meet chat. For public comment, if you would like to provide public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you, and I will leave that to Dr. Cannon.
Thanks, Noon. Good morning, everyone. Appears we have a quorum. We'll call this meeting to order. Moving us along, everybody should have gotten a copy of the minutes from our meeting in July. Ask if there's any comments or suggestions about those minutes.
May I propose?
You bet.
Yeah. So may I propose that we accept the minutes as drafted?
All right, we have a motion to accept the minutes from Kumar. We have a second.
This is Dr. Siegfried. I second the motion.
Thanks, Dr. Siegfried. All those in favor of approving the minutes?
Aye.
Aye.
Any opposed? All right, the motion carries. Noon, do we have any housekeeping that needs to be handled by the state today?
There's only one housekeeping item that we would like to let the board know that the pharmacist Joe Busby has retired from his position from the Utah Medicaid pharmacy. His last day was Tuesday, and we are currently in the process of interviewing the candidate to replace his position.
All right. A lot of us have known Joe a long, long time, and so wish him the best. With that, we have Hemogenics on the agenda, so we will turn that over to the University of Utah. I'm not certain who's on to present from the University of Utah today.
Good morning. I'll be presenting today.
Thanks, Valerie.
Let me pull those up. The slides up here. Okay, can you see those? Okay. So today we're reviewing Hemogenics, which is the first gene therapy that has been approved for hemophilia B. Hemophilia B is a rare lifelong bleeding disorder characterized by a deficiency of clotting factor 9. Significant deficiency of this factor impairs the normal blood coagulation process. This causes excessive bleeding with trauma or surgery and spontaneous internal bleeds, commonly into joints. Not only are internal bleeds acutely painful, recurrent joint bleeds cause arthropathy, chronic pain, lifelong disability, and decreased quality of life. Disease progression can lead to the need of joint fusions or replacement. Other complications with severe disease may include seizures and paralysis if bleeding occurs into the brain, or death in the event of an unstoppable bleed or bleed into a vital organ. Patients with hemophilia express that the condition negatively impacts their educational, career, and recreational choices and opportunities. Since this is a sex-linked recessive disorder, it primarily occurs in males, It's estimated that only 3% of hemophilia B cases are in females. The estimated prevalence of hemophilia B is 3.8 cases per 100,000 males. The severity of disease is classified based on factor IX activity level. Factor activity is generally correlated to a particular bleeding phenotype. However, there is not perfect correlation, so there is some phenotype heterogeneity among each severity class. It is estimated that 2/3 of patients with hemophilia B have moderate to severe disease. Patients with severe disease tend to average spontaneous bleeds on a monthly basis if they aren't otherwise treated prophylactically with replacement factor therapy. In general, patients with symptomatic hemophilia are managed with replacement factor products to raise levels of the deficient factor either on an episodic basis or prophylactically combined with episodic treatment as needed. Episodic treatment is when replacement factor product is given only in the event of an active bleed, and in prophylactic treatment, replacement factor is administered on a continual basis to maintain adequate factor activity levels. Since prophylactic therapy can convert patients from a severe bleeding phenotype to a mild or non-hemophilic bleeding phenotype, it more effectively minimizes the associated long-term sequelae compared to using episodic treatment alone. So prophylactic therapy is the supported standard of care for patients with severe hemophilia B as classified by factor activity level, or for patients with hemophilia B and a severe bleeding phenotype, regardless of their factor activity level. Nonetheless, prophylactic treatment does have its caveats, such as being a very time-intensive treatment. Part of the motivation for developing gene therapy is to eliminate the need for burdensome prophylactic treatment regimens and to minimize the limitations that the disease and usual treatment places on patients. The frequency of administration and the IV route of administration that's required with prophylactic therapy confer considerable treatment burdens. Depending on the replacement factor product, IV infusions are required twice weekly with standard products to every other week with long-acting products in order to maintain adequate factor activity levels. Although not so common in hemophilia B, patients can develop persisting neutralizing antibodies against their replacement factor product. These antibodies are called inhibitors. And inhibitors can render the replacement factor ineffective and pose clinically complex scenarios. Other complications with replacement factors include IV access issues, such as infections at the implanted infusion port. Even with prophylactic therapy on board, patients may experience occasional residual bleeds that progress joint damage. So providing more effective treatment is also an opportunity for gene therapy. In general, the general therapeutic aim of gene therapy is to provide a one-time dose of the therapeutic gene from which the body can produce sustained and adequate factor activity levels to convert the patient to a non-hemophilic phenotype indefinitely. Effective gene therapy would allow patients to discontinue prophylactic therapy, lowering the burdens of disease and therefore improving quality of life. So Hemgenix is indicated for adults with hemophilia B who meet at least one of the following characteristics. They should currently be using prophylactic therapy, or they may have a current or historical life-threatening hemorrhage, or they have had repeated serious spontaneous bleeding episodes. Hemgenix is composed of a non-pathogenic, non-replicating, adeno-associated viral vector that serves to transport functional factor IX gene copies to target cells for expression. Liver cells are the target for delivery for the genetic material where the gene is expressed to produce functional factor IX and thereby increases systemic factor IX activity and lessens hemophilia B sequelae. Depending on titer levels, pre-existing neutralizing antibodies to the AAV vector could render the product ineffective. And sources of hepatotoxicity may also interfere with the liver's ability to express the therapeutic gene. So the phase 3 pivotal trial for Hemgenix is a single-arm, open-label study that included 54 patients with severe or moderate severe factor IX deficiency. In other words, included patients had a factor activity of less than 2% or less. Additionally, patients were required to be on stable continuous factor IX prophylaxis for at least 2 months prior to screening. To control for confounding factors, characteristics that disqualified patients for inclusion included uncontrolled HIV infection, active hepatitis B or C infection, advanced liver fibrosis, history of factor IX inhibitors, or liver or renal laboratory results greater than 2 times the upper limit of normal. During a 6-month lead-in period while receiving prophylactic treatment, bleeding events were recorded to establish the patient's baseline frequency. The study population's baseline annualized bleed rate was 4.22 episodes with prophylactic therapy, and 39% had detectable neutralizing AAV antibodies at baseline. The majority of enrolled patients had severe factor IX deficiency at diagnosis, and the remainder, or 19%, had moderate severe deficiency. Following the single IV dose of Hemgenix, the primary endpoint was assessed as the annualized bleeding rate during months 7 through 18 post-administration compared to the baseline rate. The annualized bleed rate decreased from 4.2 episodes to 1.5 episodes following treatment, representing a 64% decrease. The outcome was statistically superior to pretreatment conditions with prophylaxis. Spontaneous bleeds and joint bleeds decreased by 71% and 78% respectively following treatment. Subgroup analysis suggested that the effect on the main outcome was lost only in the presence of pre-existing neutralizing AAV5 antibodies above a titer of 678. There is no clinically significant impact with lower titer levels. An increase in the mean factor activity was observed by week 3 following Hemgenix administration and continued to increase to month 6, then was sustained through month 24. Nearly all patients who received the full dose of Hemgenix, so 98% of patients responded to therapy and were able to discontinue prophylaxis. One patient who had the highest baseline AAV antibody titer did not respond to the full dose of Hemgenix and required continuation of prophylaxis. One other patient received a small fraction of the dose, about 10% of the dose, since they prematurely discontinued the infusion due to a hypersensitivity reaction. And this patient did not respond to the partial dose. The annualized consumption of factor IX replacement products decreased by 97% after Hemgenix administration. Noteworthy common adverse reactions with Hemgenix are liver enzyme elevations, which occurred in 42% of treated patients, and infusion-related reactions occurring in 33% of patients. So there are corresponding labeled warnings for these. Infusion reactions may require a temporary pause of the infusion or rate reduction or supportive treatments. But overall adverse events with the gene therapy were primarily of mild grade. Hepatotoxicity is possible with AAV-based gene therapies in general, but can be managed with corticosteroids. And an elevation in liver enzymes within the first 3 months of Hemgenix signals an immune-mediated injury of the transduced hepatocytes, which can reduce the gene therapy effect. So it's very important that liver enzymes or liver elevation is promptly treated with corticosteroids to maintain liver integrity and the gene therapy effect. Other warnings are regarding a theoretical risk for hepatocellular cancer, and there is a warning regarding pre-existing anti-AAV5 antibodies, which is mostly educational to encourage participation in the clinical trial that will further assess the effect of baseline levels on outcomes. This slide consolidates the monitoring that is required in the package insert. Since it is critical to catch an immune-mediated reaction, liver enzymes should be monitored weekly for the first 3 months after administration of Hemgenix. Factor IX activity should be monitored also weekly for the first 3 months. And other liver health parameters are recommended for annual monitoring in at-risk patients for liver cancer. Providers should also continue monitoring for signs of factor IX inhibitor development as clinically indicated. Oops, let me back up. Here we go. Okay, so before I talk about potential prior authorization criteria, I'll summarize some key points presented. So Hemgenix is the first gene therapy for hemophilia B. It's indicated for the treatment of adults with hemophilia B. There is one phase 3 before and after supportive study, which included male patients with severe or moderate severe disease, in particular with a baseline factor activity level of 2% or less. Pre-existing neutralizing anti-AAV5 titers of 678 or less did not appear to modify the gene therapy effect, but higher titers did. Hemgenix is not a cure per se, but it can omit the need and treatment burdens of prophylactic replacement factor therapy in most patients with severe disease. Patients will require continued prophylaxis after gene therapy administration until adequate effects are obtained, which may take several weeks to 6 months. And even after a response, patients may require episodic replacement factor treatment occasionally for planned surgeries. There is no robust evidence to support administration of more than one treatment course in a person's lifetime. For example, if factor IX activity response begins to decline below adequate levels. And there are no studies in pediatric patients. The common adverse effect of elevated liver enzymes necessitates frequent liver enzyme monitoring after administration and may require short or long-term corticosteroid treatment to manage hepatotoxicity and maintain the durability of transduced hepatocytes. So potential prior authorization criteria may include requirements to meet the FDA indicated age for use and to meet at least one of the following criteria in bullets. You may also consider requiring that the patient meet a certain factor IX deficiency level corresponding to severe or moderate severe factor IX deficiency. Although this criteria is not specifically from the labeled indication, it represents the particular population that safety and efficacy were demonstrated in. Hemgenix was not studied or established in patients with mild hemophilia B. And prescribing may be restricted to hematologists. You may have the prescriber attest or document certain pretreatment laboratory assessments to determine whether the patient is a candidate for treatment, such as factor IX inhibitor testing and liver parameters. You may also require that the patient not have one of these listed conditions, which were inclusion criteria for the clinical trial, since they could theoretically decrease the efficacy of treatment. The patient should also be counseled to promote realistic patient expectations and to assure that they understand the intensive monitoring requirements and potential side effect risks. For example, patients should be counseled about the potential need for immunosuppressive therapy, possibly long-term or multiple treatment courses for the management of elevated liver enzymes. And patients should also understand the side effects of corticosteroids. Patients should be aware that even with gene therapy, replacement factor treatment may be required in the event of a non-response to gene therapy or episodic breakthrough bleeds or for planned surgeries. And you may require the prescriber to follow monitoring recommendations at least as frequent as stated is in the package insert. And coverage authorization can be limited to a single lifetime dose. And that's all I have today. Thank you.
Thank you. Kumar, you had a question?
I heard that pediatric patients were excluded. Is there a technical reason for that, or what might be the reason?
I'm not sure. Sometimes with these rare diseases, they start, with adults first and go from there. But yeah, pediatric patients have not been included.
So in future, perhaps, right?
Yeah, maybe.
Thank you.
Thanks, Kumar. Anyone else have any questions or comments for Valerie?
I have a question.
Yeah, go ahead.
I was wondering the reason for the HIV, like what the mechanism is, if you know it.
Well, they excluded patients with uncontrolled HIV.
Yeah.
So I don't know if that's just like compromise of the liver concern, to where, because it's the liver that is that expresses the therapeutic gene. So you can't have, like, they excluded patients with severe liver damage like fibrosis and things like that, because you need enough functional liver cells to be able to transduce and then produce that gene, or I mean express the gene.
I'd suspect also it's complicated for immunosuppressive therapy if they would get complications with active HIV uncontrolled, right? Because there's also a caveat later down for other conditions that might complicate that aren't specified, but that I think is an obvious one.
All right. Thank you. Thanks, Catherine. Thanks, Dr. Weinstein. Any other comments, questions? All right, Noon. Oh, Dr. Brinton just came on camera, so she must have something for us.
Well, no, do we have public comment on this? Because my comment more relates to what the hematologists, kind of some of their things. Is there public comments? Because if so, I'll wait till after they speak.
I did not have anything on my agenda. Noon, do we have any public comment?
We don't have any requests for public comment this time.
Okay. All right. Once we get to the, to talking about our prior auth, but I do just want to say, you guys, I had some third day of their life medical students with me yesterday, and we were talking about some SMA kids and showing the difference between therapy before and after we had these gene therapies. It's been so amazing to have SMA and Duchenne's and cystic fibrosis and now hemophilia treatments for these patients, and that'll eventually trickle down to our pediatric world too. But I'm just so grateful that our team has been so supportive of really trying to make sure that the right therapy gets to the right person at the right time and do it in a safe way. I think we've done a really good job with that. I'm just really excited to have a new therapy that could be helpful and to figure out how to do it in a good, safe way. So thanks, team.
Yeah, no, thank you. I think, we have seen major advances here in the last, 5, 6, 7 years that have really changed the face of treating several disease states. So it's exciting. It's also troubling as we try and make sure that we have the resources to take care of everybody. So Noon, turn over to you to talk about the PA criteria.
Just give me 1 second. So this is the proposed Hemgenix prior authorization. The criteria, all of the following criteria must be met. The prescriber prescribed by a hematologist who is specializing in the care of patients with hemophilia B, requiring to be a male patient 18 years of age or older. The patient has negative, I'm sorry.
I can't see anything.
Oh, my
I
apology.
don't know if I'm the only one. It's a lovely picture of you.
Oh, I'm sorry. Let me share my
I could see
screen.
it.
Oh, you could see it? Okay, must be me. Keep going.
Okay. So does it show yet?
No, I can't. Yeah.
Okay. My apology. So this is the Hemgenix prior authorization criteria. The criteria for approval, all of these following criteria must be met. Prescribed by a hematologist specializing in the care of patient with hemophilia B. Require a male patient who is 18 years of age or older. The patient has a negative adeno-associated virus serotype neutralizing antibody assay. The patient has negative factor IX inhibitor titer. Patient have confirmed diagnosis of hemophilia B, congenital factor IX deficiency, currently use factor IX prophylaxis therapy, or has current or historical life-threatening hemorrhage, or has repeated serious spontaneous bleeding episode. Provided a test that the patient has complete liver health assessment and has no liver abnormality are found, including the enzyme testing, ALT, AST, ALP, and total bilirubin, and has hepatic ultrasound and elastography. The provider attests to complete on-post infusion monitoring described in the current Hemgenix prescribing information. Only one intravenous infusion not allow re-auth on this medication, and a note for medical billing. As noted, this prior auth has been vested by the Hemophilia Treatment Center.
All right, Dr. Turner.
Why do we require a negative adeno-associated neutralizing antibody when it was shown to be fully effective in people with titers below, what was it, 678 or something like that?
Yeah, thank you, Dr. Turner. That is one of the criteria that we have been discussed over, as this medication is one of the very high cost medication, with the cost could be above $1 million. So this is one of the way that we try to ensure that the patient who would likely to be effective for this medication or could be receiving the best outcome for this medication.
I just want to point out or emphasize that, patients were with the neutralizing antibodies were included into the study. About 40% of the patients in the study were positive for neutralizing antibodies, and almost 100% of those patients did respond to therapy. There was only one person of that 40% who didn't respond, and so that's kind of why they're looking at the titer level, because it's not necessarily a matter of it just being positive. It's more to do with like what the titer level is, because patients with the lower titers were seen to respond to therapy. that was just one of my concerns too, or just some information I wanted to point out as you're thinking about that criteria.
Thank you.
All right, Dr. Britton.
So could we do an amendment to put down just patients with high antibody titers, or is there a number on the antibody titer that we should look at? I'd hate to exclude a major portion of patients since adenovirus is such a common, virus out there. Like, well, if we did a, well, I guess I'm asking this, if we made a motion, what would be the numbers there that would actually be clinically helpful?
I think based on what the phase 3 trial has shown so far, that titer that threshold that they pointed out was 678, but the FDA did not decide to go in and like put in the label that a test had to be done, because there is actually no FDA approved assay for measuring AAV5 neutralizing antibodies. So they mandated a post-marketing study once an assay does become available. But the drug company does offer the testing that they used in the study to providers to, kind of screen for neutralizing antibodies, but the FDA didn't put that type of language into the indication or the package insert for those reasons. So yeah, there's no like contraindication right now that they have in the package insert for neutralizing AAV5 antibodies.
So it sounds like maybe, I guess I would maybe make a motion, which of course I'm happy to, feel free to like knock it down or adjust it, to strike that that part, since it's not part of the FTA part. We know that our hemophilia providers are not just willy-nilly throwing things at people. They've looked at this, so I guess I'd make a motion to strike that one. See what you all think about.
I'll second that amendment, and for that reason, as well as if the thought behind it was to balance some cost efficacy equation, I don't think we have sufficient data to do that. In terms of there being responsiveness for people with a titer, and we have some break point on a low titer, there are patients who are still responding. My understanding of our charge is not to do that kind of rationale in these decisions. So I do understand this could turn out to be, this is an expensive therapy for sure, relative to others. But for the fact that we don't have an approved assay, as well as it's not in the labeling, and there are patients at low titer in the study that are responsive, we don't have a break point to say. That it seems to me, it's the third, is it the third one we're striking on this? Then, yeah, I'd support that amendment.
Well, let me ask a question then. Along with your suggested amendments, is that a motion that we approve the criteria after we've striked that line?
Well, I had
See
another
a smile
question.
and a nod from Dr. Britton.
I have another question. If
Okay.
I realize that female patients weren't included in the study, and there aren't very many of them, are we waiting for, and do we know if there are any trials underway studying female patients?
I'm not aware of any trials in female or plans. I think it's extremely rare that you have a female hemophilia B patient, and then also to be targeting a certain severity. So like a female with severe disease is extremely rare. So it's probably more of a enrollment issue, if they can even get that type of person. So I don't know if there'll ever be like a robust study done, because there might not be enough females with that severity at one time to do a study.
So I think Dr. Weinstein, I mean, if we build this PA criteria based on the evidence would say we stick to males, although we would know that the state has the ability to run an exception process beyond that. Is that correct, Noon?
Yeah, that is correct.
Okay.
So
Right.
we're seeing XY chromosome male.
Yes.
Okay. Sorry.
Okay, Dr. Smith, your hand is up.
Right. And I don't mean, I'm not meaning to be provocative in that conversation, just, you know,
Right.
understanding the genetics and the way the disease presents is a recessive. That's why we're putting this way. And
Right.
the likelihood that there would be, you know, the numbers and the likelihood that this would present in an XX female, it's just so unlikely that we're not excluding patients, and we do have a mechanism under an exception or a compassionate use or something like that equivalent, if there's a hematologist who has a patient they want to treat, that there's a mechanism to do that, and that would be exceedingly rare. So that wouldn't be something to address in the PA. Then I'm good. Thank you.
All right.
Dr. Smith.
Thanks. I would like the committee to consider just striking male in general, because you end up bringing up possible barriers for people who are intersex or trans, who may have an XY but don't have female as their sex of record. I just think it's not needed.
Other comments on Dr. Smith's thought? And I see where you're going. I think, I mean, part of me says we accept the fact that we only have one hemophilia treatment center in the state, and they're not, my assumption would be that they're not going to run out and just kind of use this at will. But I'm curious, and then any other thoughts from the committee?
So then we're just concerned with the age. So say patient is age 18 or older.
Correct.
Noon, how does the state feel about that?
Would stating as the patient is male at birth, would that address your concern, Dr.? Okay.
No, because you could have intersex people, and we aren't doing genetic testing, and it just doesn't make sense.
Yeah, the board can make the motion, and we will likely to take that into consideration for one of the motion.
Can I make that as a motion to just strike male and just say patients 18 years of age and older?
And I'd second.
Okay, so we struck male. We struck bullet number 3, correct? All right. I'm not certain how I feel about striking male, but I will say given the fact that we're talking about something that is just so incredibly rare. So noon, we'll make those recommendations that we strike those two. And anything else from the committee?
Rick, we have a motion, but we didn't have a vote. So can we have a vote on those?
So the vote is, and the motion is, we have two motions. Strike line 3, strike male. All in favor?
Aye.
Aye.
Any
Aye.
opposed? All right, not hearing any.
And Eric,
Yes.
I will abstain just due to a potential conflict of interest with my employer. So I'll abstain from voting today. Thank you.
All right. No, thank you, Neil. We'll
You betcha.
recognize that for the minutes. We
Thank
appreciate
you.
that. All right. Do we have a motion to approve the recommendation as it is now?
I move we accept the PA as amended.
All right. Thanks, Dr. Turner. Do we have a second?
Second.
Dr. Weinstein is our second. All right. All in favor?
Aye.
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 All right. Any opposed? All right. That passes. Noon, unless there's nothing else, we appear to be discussing insulin pumps in September on the 14th. So we're all excited for that. And is there anything else we need to cover today?
That's just all. Thank you very much for the attendance. and the
All right,
discussion.
guys. Hey, congratulations. 3 minutes before 8.
Thank you, Dean.
Keep things moving. All right, guys. Appreciate all your help. Thank you for your support, your participation. And with that, do we have a motion to adjourn?
I'll move we adjourn.
Okay, I
Second.
guess that's not a conflict. Thanks.
That's not a conflict there. No, we're good. I can participate.
All right, we have a motion to adjourn. We have a second. I assume everyone's in favor. Thanks, everybody. We will see you all in September.
Bye, everyone.
Cool.
Aye.
Bye.